Now, poles of the cerebral hemisphere. Now, this is the brain. Now, this is the central sulcus, parietal lobe, frontal pole, lateral sulcus. This is lateral sulcus. This is temporal lobe, and temporal lobe here. The pre-occipital notch, occipital pole, occipital lobe. Now, frontal pole, anterior end of the cerebral hemisphere, more round than occipital pole. Occipital pole, posterior end of the cerebral hemisphere, more pointed than frontal pole. Now, temporal pole, anterior end of the temporal lobe, it lies between the frontal and occipital lobe, round and directed forward. This is the anatomical position. When you ask to hold the brain, these are the criteria that you hold the anatomical position. Not like this, the frontal lobe with piche laga, aise ulta do. That happens actually. It happened to us even also. I just can't understand why you're not serious. Now, cerebrum, external features, external cerebrum, external features, poles, frontal, occipital, temporal. Surfaces, superolateral, medial, inferior, orbital, tentorial. Now, the position of the brain, relation with the skull bone. Now, that gives the surfaces, superolateral, medial, inferior, orbital, tentorial. You have to know the skull very well. Then you can correlate the brain's anatomical position up. You just don't take the brain like this and just ulta palta ghumate raho. Don't. You have to be very 2 or 3 points to remember, to hold it in anatomical position. It is not like taking this brain and just moving like this, Don't. You see the contour, the surfaces, the lobes, that is descriptive. It's very easy to describe this. Now, borders, superomedial, superciliary, infralateral, medial orbital, infromedial, medial occipital. Now, occipital, orbital, ciliary, these are the bones of the skull that is related to. The lobes, frontal lobe, parietal lobe, temporal lobe, occipital lobe, insula. Now you can see the picture of the brain, the lateral surface and the undersurface of the brain. I will put this specimen in the dissection hall, not in your lab or demo room. It will be there in 2 tables. Please look into it. Now, 3 surfaces of cerebral hemisphere. Superolateral surface, convex, faces upwards and laterally. Medial surface, flat and vertical. It is separated from the medial surface of another hemisphere by longitudinal fissure and connected by C-shaped corpus callosum. So this is connected. The 2 surfaces like this. There's a cleft. You just gently move, see the cleft and you will see the corpus callosum. Now you will have a sagittal section of the brain in the specimen. You see it. Now, surface of cerebral hemisphere, inferior surface divided into orbital surface, small anterior concave part that rests on the root of the nose and orbit. In this part, root of the nose and the orbit, this part. And tentorial surface, large posterior part that rests on the floor of the middle cranial fossa and on the tentorium cerebelli. in this part. Now, borders of the cerebral hemisphere, the superomedial border separates superolateral surface from the medial surface. Infralateral border separates superolateral surface from this orbital part of the inferior surface. Superciliary border, anterior part of the infralateral border, which separates superolateral surface from now medial orbital border separates medial surface from the orbital part of the inferior surface. Medial occipital border separates medial surface from the temporal part of the inferior surface. Inframedial or hippocampal border separates the inferior surface from cerebral peduncle or midbrain. Now, lateral cerebral sulci or sulcus, lateral sulcus, Sylvian sulcus. The deep sulcus has stem and 3 rami follows. Stem of lateral sulcus begins on the inferior surface of the cerebral hemisphere and separates orbital surface and the temporal pole. On the superolateral surface, the lateral sulcus divides into 3 rami. Yeah. Now, main cerebral sulci, lateral sulcus. On the superolateral surface, the lateral surface divides into anterior ramus. Yeah. This is central sulcus, the precentral gyrus, the precentral sulcus. Now, this is the inferior frontal gyrus, middle frontal gyrus, superior frontal gyrus, superior temporal gyrus, superior middle temporal gyrus, inferior temporal gyrus. Yeah. Now, the anterior ramus passes forward into inferior gyrus, anterior ascending ramus 2.5 runs upward in the inferior frontal gyrus, posterior ramus runs posteriorly and upward to the inferior parietal lobule, its posterior end upturns sharply. Now, main cerebral sulci, central sulcus of Rolando, begins on the superior medial border of 1 cm behind the midpoint between the frontal and occipital poles. There. This is the occipital, this is the frontal. Runs downwards, forwards at 70 degrees angle to reach the posterior ramus of the lateral sulcus. And its upper end extends into medial surface. Now, main cerebral sulcus, parieto-occipital sulcus, parieto-occipital sulcus begins at the midpoint of calcarean sulcus, runs upwards and backwards, slightly backwards to the intersect supermedial border, extends slightly on the superolateral surface. This is the section cut. You can see the corpus callosum, and these are the sulci and gyri. This is the uncus. Main cerebral sulcus, calcarean sulcus. Present only on medial surface, begins inferior to the posterior end of the corpus callosum, splenium, runs posteriorly with upward convexity to reach the occipital lobe, extends for a short distance on the superolateral surface. Now, lobes of the frontal hemisphere, the frontal lobe lies anterior to the central sulcus and above the posterior ramus of the lateral sulcus. This is the frontal lobe, this is central sulcus, this is the lateral sulcus, posterior ramus, this is the temporal lobe, this is the occipital lobe. Now, lobes of the cerebral hemisphere, parietal lobe. Parietal lobe lies behind the central sulcus and in front of an imaginary vertical line joining the parieto-occipital sulcus and pre-occipital notch. This is the pre-occipital notch, this is occipital pole, the lateral sulcus, this is the temporal lobe, frontal lobe, central sulcus, and parieto-occipital sulcus. This is the lobes of the cerebral hemisphere. Temporal lobe lies below the posterior ramus of the lateral sulcus, the lateral posterior ramus. This is the portion of the, in yellow, this temporal lobe, horizontal lining extending backwards from horizontal part of the sulcus, and lies anterior to imaginary vertical line joining the parieto-occipital sulcus and pre-occipital notch. Pre-occipital notch, this portion is the temporal lobe. Lobes of the cerebral hemisphere, occipital lobe lies behind the vertical line joining the parieto-occipital sulcus and pre-occipital notch. Now, insula or cerebral central lobe. Now you can see this is the central sulcus. The portion of the brain is retracted. The luminal insulae, gyri brevia, and frontal operculum. This is frontoparietal operculum. But you just know the gyri longa, the central sulcus. Submerged or hidden part of cerebrum, insula or central lobe, part of cerebrum, pyramidal elevation that lies deeply at the bottom of the lateral sulcus. To visualize the insula, separate the margins of the posterior ramus of the lateral sulcus. Triangular apex is called lamen insulae, which is continuous with the anterior and circular sulcus separates insula from part of the brain except at the lamen insulae. Insular opercula, part of the cerebral hemisphere that hide the insula. Insula is divided into two regions, anterior and posterior by central sulcus. Anterior region represents 3 or 4 short gyri called gyri brevia. Posterior region represents 1 or 2 long gyri called gyri longa. Functions control emotion, body hemostasis, empathy, taste, self-awareness, and so on. Now, this is a very small place. The insula is divided into two regions, anterior and posterior by the central sulcus. But anterior region presents 3 or 4 short gyri called gyri brevia, and posterior region presents 1 or 2 long gyri called gyri longa. But the main is the function. The function of this part of the insula or the central lobe. It controls the emotions, body hemostasis, empathy, taste, self-awareness, and so on. Now, insula controls this. Controls the emotion, body, hemostasis, empathy, taste, and self-awareness, and so on. The sulci gyri you have to practice, okay? And the medial surface of the cerebral hemisphere, this is the medial surface. The sulci anterior para-olfactory, posterior para-olfactory, cingulate and callosal, suprasplenial, parieto-occipital, and calcarean. Gyri, para-terminal, para-olfactory, medial frontal, paracentral lobule, cingulate, cuneus, precuneus. Main condition, the thing is that you know the major component, the lobes and the gyri, the central sulcus, and the function of those lobes and those areas. This is the under surface of the brain, this is the midbrain, the tubular cynarium, mammillary bodies, and anterior perforated substance here, uncus is here, olfactory sulcus, olfactory bulb, frontal lobe, this is the occipital lobe, rectus, anterior, posterior, medial, lateral, orbital gyri, lingual uncus, parahippocampal, medial, occipitotemporal and lateral occipitotemporal. Types of cerebral cortex, this is important. Phylogenetically, the cerebral cortex is divided into three types. Archicortex or archipallium can be a short note. Archicortex or archipallium can be a short note. Phylogenetically, the oldest, it includes hippocampus and parts of the rhynencephalon. It consists of three layers of neurons. Paleocortex or paleopallium, intermediate in development, it includes cingulate gyrus. Neocortex or neopallium, most recently evolved part. It includes most of the part of the brain. It has 6 neuronal layers. It is of two types, agranular or motor cortex and granular or sensory cortex. See, you please take note of this part. It can be a short note. It can come as an MCQ. What is in 1, 2, 3 components. That can be one in MCQ. But short note comes types of cerebral cortex. This is very important. Archicortex or archipallium, paleocortex or paleopallium, and neocortex or neopallium. This is very important. You must know the Sulci and Gyri. You must know the lobes of the brain for viva and also for short notes. You don't go into the small details of what is there, but at least you have to know the types of cerebral cortex, this part, plus the lobes of the brain, plus the function of the part. I requested you the other day, have you downloaded that picture of the brain you've seen in Gray's Anatomy, 34th, 35th, 36th edition? How many of you downloaded? Please raise your hand. One only. A great guy you are. So out of 120 students, only one dared, I would say dared to download. Why I use this term, adjective? I told you, you just casually, like you see some prawn, you are seeing some prawn in midnight. Like that you just see. Or you see some beautiful Hindi video, Hindi song, Shah Rukh Khan. Think that you are seeing that part of the brain. Please go home today and download or that picture. Now, histology of cerebral hemisphere. These are small triangular cells, histology of cerebral hemispheres. They are present mostly in external pyramidal layer of cerebral cortex. Their axons travel towards the surface of the cortex. Stellate neurons, these are small multipolar neurons. These are star-shaped neurons. These neurons look similar to granules that are called granular neurons, horizontal cells of Kajal. These can come as a MCQ or short and fusiform cells. They are fusiform cells that are long. There's a very beautiful picture in the histology lab, because in HN stain, what we show you in the cerebrum is not the Kajal stain is different. So you take for your own interest, you just see the picture from your histology book, and if you want to be more, there is more good clarity, you please see it in your histology lab. You have beautiful picture in the wall. Now, lateral layers of the cortex is HN stain. The pyometer, small pyramidal cells, medium pyramidal cells, granule cells, large pyramidal cells and bundle of axons here. You can see. Even this is in your histology book, or if you want to see it in large form, then you see it in the histology lab. See this red, internal granular layer, internal pyramidal layer, and multiform layer, a layer of polymorphic fusiform cells, white matter, functional areas of cortex. Now, this is again, it will be, you please see the Gray's anatomy, and you see a man's hand, foot, it's drawn as a very good visualization of the cortex and its function. You please see that picture. Motor areas control motor activity and give rise to corticospinal and corticonuclear fibers. Sensory areas receive afferent sensory fibers from the thalamus and subthalamic nuclei. Association areas responsible for modification of motor activities, interpretation of sensory input, intellect, emotions, and so on. Brodmann has numbered these areas as Brodmann, German neurologist, 18,068 and 19,018. These are called Brodmann's areas. It can be a short note, Brodmann's area. See, this type of classification in 1868 to 1918, Brodmann was born. In this period he worked and he did such wonderful thing that has not changed, the anatomy. And see, with minimum instruments, that so sophisticated microscopes were not there. See, these are the areas. The primary somatosensory, primary motor cortex, premotor cortex area, frontal eye field, perifrontal areas, motor speech and Broca's area, and sensory speech area, visual areas, association areas, primary visual area. Now, primary auditory area and secondary auditory area. Now, this is the functional areas of the superolateral surface of the right cerebral hemisphere. Here is the picture. This is the picture I was speaking of. Now see, this is the picture. Motor areas, primary motor areas, board. Body is represented upside down, except as face as follows. See, upside down. Now, these are the areas, the vocalization, swallowing, mastication, this motor area. Now, this is represented by this drawing. So, these are the cerebral areas. Now, one thing, if there is any, like clinically, so there was no ultrasound, no MRI, CT, or your different types of modern radio imaging techniques. But these is not available everywhere. A CT report or an MRI report takes 2 days. In Calcutta also. That doesn't give. So, at the end of the report, yet the radio diagnosis, he is supposed to be the super specialist doctor. He says clinical correlation must be. Now, this is, I think, that it is up to you. You take decision of the diagnosis. So, your clinical knowledge, clinical foundation is a must for a good MBBS. A good MBBS is a good postgraduate. Online जो भी होगा, अब ले लो to fill your basket. But clinically, at least on the spot, for your own interest, you try to see and visualize that what is gone, which area has gone wrong. Now, this is the area, anyway, you can, but see, this is the leg portion, this is the foot, trunk, this is the hand, thumb, neck, this is the face, beautiful, the tongue. Now, any motor area that is not functioning, then you think of which part of the brain is gone wrong. It can be by contusion, it can be by cerebral hemorrhage, or any trauma. Now, see, lesion of motor areas causes upper motor neural paralysis of opposite half of the body, hemiplegia. Now, when you see a patient come with a paralysis, hemiplegia, quadriplegia, paraplegia, you just clinically, quick with your hammer and pin, you do your diagnosis in your worksheet and put this. You call your boss or you send the report, but if you wait for first you write MRI, CT, that doesn't work. Ultimately, I'm telling you, even AIIMS in Delhi, all these facilities, as not within 24 hours or within half an hour or 1 hour or 2 hours or 3 hours, the report doesn't come. So you have to depend on your clinical practice and you have to know the minimum. These are the things you can easily remember and you can have in your content. Premotor area or area of Brodmann, location anterior to motor area is the posterior part of the superior, middle and inferior gyri. Functions main cortical center of extrapyramidal system, programming and control of intended movement. Lesion of premotor areas produces difficulty in performing skilled movements. Now, you know the gross anatomy of the brain and the areas functional, which is motor area, which is sensory area, and how it is coordinated in the cerebellum or other regions of the brain. So, you make a provisional diagnosis and try to take a self-test. This is a patient I'm seeing, you taking your provisional diagnosis. That should be accurate. So, and then you correlate with your modern investigation. Now, the functions, main cortical center of extrapyramidal system, programming and control of intended movements, lesion of premotor area, difficulty in performing skilled movements. Supplementary motor areas, location medial frontal gyrus and gyrus on the medial surface of the hemisphere anterior to paracentral lobule, and this is the paracentral lobule here, anterior to it. And function control bilateral complex movements which requires sequential organization. Motor speech areas, 44, Broca's area. This is a short note. It can be a short note. It can come in MCQ. Broca's area. What is Broca's area? Location in the inferior gyrus dominant left cerebral hemisphere includes pars triangularis area 45, pars opercularis area 44. In right-handed individual, 70% it lies on the left cerebral hemisphere. In the left-handed individual, 30% it lies in the right cerebral hemisphere. You think of Bachchan. So, the 30% is left-handed individual and 70% is the right-handed individual. Motor speech area, the sensory speech area is this portion. This is the primary auditory area, secondary auditory area. Motor speech area is this, Broca. Broca's motor speech area. Now, motor speech area, Broca's area, functions initiate the movements of production of speech. It controls expressive language and capacities, grammar. Lesion results in motor aphasia, that is loss of ability to produce express speech. The person can write the words but cannot speak. So, you can ask the patient to write something. Like I tell you, a boy of class 8, one evening, his maternal uncle and grandfather came to me. They told me that the boy returned from school, now he doesn't speak. He could not speak. And then what happened? They asked me to refer to some doctor in Brodmann, as I was a student of Brodmann Medical College. So, Dr. Ashok Dandapat, he's an ENT surgeon, ENT consultant. In those days, he was a registrar in ENT department. What happened? But I told them that would I see the patient, because without seeing the patient, I won't refer. Because ultimately, if I send it, I had sent it to Ashok Da, I would call. Then, after seeing him, he was our registrar, that means he was my teacher. He would say that, Probas, তুমি এটা করতে পারোনি, এটা diagnosis করতে পারোনি. That would be very humiliating to me. So what I I took the boy in my chamber, and his mama and dadu were requested them to sit in the waiting area. Then what happened? I started talking to him. He is not answering actually. He is very stubborn. He was, at that point of time, he was just doesn't want to talk to anybody. Then slowly what I did, I say, I am your friend. You can tell me. Then what I did is that I asked, আরে তুই কোনো মেয়ের সঙ্গে প্রেম করিস বা তোর কোন মেয়েকে ভালো লাগে? Do you love any girl in your class? You are in some affair with your classmate? Suddenly he got bit, yes, he became like this. I told him, no one is hearing you. No one is there. আরে বাবা কথাটা আমার সাথে বল, তারপরে তুই চুপ হয়ে যা. I told him that you speak to me, you just say what happened to you. He gave a smile. Then what I did is that I told him, তাড়াতাড়ি বল. From 6 p.m. to 10:30 p.m. I interrogated, I just discussed with that boy, and ultimately, then I told him, you are feeling shy. না ও আবার আমি ওকে ভালোবাসি আর দেখলাম ও একটা ছেলের সাথে চলে যাচ্ছে। এটা 20 years back, 20 to 25 years back. ও তোর মন খারাপ হয়েছে? আরে তুই আর একটা মেয়ের সাথে প্রেম করবি, আমরা বিয়ে দেবো তোর, আর প্রেম করবি না, পড়াশোনা কর। I told him, then now I told him that see you are feeling shy. Then আমি কথা বলছিলাম না বেলা from 3 p.m. noon. I was just, no one, I'm answering. Everyone is requesting me, ki holo, keu mereche, keu kichu koreche, have anyone hit you? Did you fight with any person? I told him, see, that I have an answer. I will examine you, I'll bring instruments, and slowly I'll give you some medicines, and I'll call your guardian. And I told him, I'd give this thing of fears I built up. I told him that, see, I send you to Brodmann, then they'll cut if they go for an operation. Then he got a bit scared, Then what I did is that I took a tongue depressor, a head mirror, and I examined him. There was nothing, the lesion is in the head. So what I did is that I called his mama and grandpa and told them, in front of them, I asked the boy, hey, what you will have for dinner? He told me that demered omelette and bhat, rice and omelette and dal. Then I told, they got a bit puzzled. I told you, don't take to, I'm not referring, I'm giving some medicine. I took some big complex and tablet and made a small puria. You know puria, you fold it, you crush the medicine and then you put it. And I told them that after food you give these two puria and tomorrow you report to me. And that got cured. See, this is the story I told you, that you have to have patience. You have to have the subject knowledge and integrity. That what could a boy coming from school, back from school, it may happen to you also. He goes into a depression, but their parents were a bit, within that 6 hours they brought to me. They stay in Nolati after Ampurat. Now one thing I tell you, that please know the basic things. Your syllabus is shortened, but if you asked to, please hold this brain. Now, in the brain and neurology table, there won't be liver. So you will take liver and start seeing something. So please come to the dissection hall. See, these 2 weeks, you are having the routine, Dr. Abhijit said, made such a routine that you revise for the day. And what I was instructed that you teach whatever you feel that it will be useful to them.